Let's go. Number one, a 17-year-old female presents with irregular menstrual cycles, severe acne, resistant to topical treatments, and excessive hair growth on her face and her chest. This patient's BMI is 32, and she has had dark patches of skin on her neck and underarms. What do you think that is? The dark patches of skin. What is it? What do you think we are talking about? A patient acanthosis nigricans. Beautiful. What is the most likely diagnosis? So this is very simple, but I still want you to answer it. Is it A, hyperthyroidism, B, Cushing syndrome, C, polycystic ovarian syndrome, and D, congenital adrenal hyperplasia? What answer will you go for? I think this one everybody knows. Okay. So the answer will definitely be polycystic ovarian syndrome. Okay. Now, what is the explanation here? And I don't want us to rush through anything. The combination of irregular menstrual cycles, okay, severe acne, hirsutism, obesity, acanthosis nigricans strongly suggest PCOS. Okay? The other options, while even though they are possible, causes of some of these symptoms do not encompass the full clinical picture. For example, congenital adrenal hyperplasia does not encompass these features we're talking about. The same as hyperthyroidism. Hyperthyroidism, I'm rather expecting the patient to be lean. Hyperthyroidism. Hypothyroidism, hypo, then I'm expecting the patient to be, to gain weight, right? Okay, so now, next question. Now we'll start getting into deeper stuff. A 16-year-old girl presents with concerns about her menstrual cycle. She reports having only 4 periods in the last year. She also has mild hirsutism and moderate acne. What is the best next step in management? What's the next best step in management? A, immediate start of oral contraceptive pills. B, further evaluation for PCOS. C, reassurance and follow-up in a year. And D, begin metformin therapy. Will you go for A? Will you go for B? Will you go for C? So she reports having 4 periods in the last. She also has mild hirsutism and moderate. What's the next best step in management? So some are going for A, some are going for B. Now, let's look at what the answer is. The answer is B. We're going to further evaluate these patients for PCOS. And this is the reason. Given the menstrual irregularity, the hirsutism, the acne, you want to further evaluate the patient for PCOS. Even though oral contraceptives and metformin are treatment options, they should only be started after you've confirmed your diagnosis. So, yes, the fact, don't get this mixed up. The fact that we are learning about PCOS does not mean that everything I'm going to put out here is about PCOS. Doctors, please, are you following my reasoning? The fact that we are learning about PCOS does not mean everything I'll put out here is about PCOS. Now, when we talk about management in the QE1, management is not only about treatment. Part of management is evaluating the patient, right? Part of management is evaluating the patient. So, immediately starting the patient on oral contraceptive pills, in as much as it is part of the treatment for PCOS, even that one, it is for a unique group of patients, like patients who don't have fertility wishes right away, right? But you realize that the question never told you that the patient's PCOS has been diagnosed yet. And so you want to be very careful about that. Okay, good. Now, next MCQ. Which of the following is not a criterion used to diagnose PCOS in adolescents? Which of the following is not a criterion used to diagnose PCOS in adolescents? A, persistent menstrual irregularity for 1 to 2 years. B, biochemical evidence of hyperandrogenism. C, presence of multiple ovarian cysts on ultrasound. And D, elevated prolactin levels. What is your answer? Is it A? Is it B? Is it C? Is it D? So it looks like a lot of doctors, those on Facebook and those in the Zoom link, are all going for D. D, beautiful. And that is it, elevated prolactin levels. So elevated prolactin levels are associated with hyperprolactinemia, not PCOS, right? And the other options are are part of the diagnostic criteria for PCOS. Now, I saw somebody make a point in the Zoom link that PCOS is now a clinical diagnosis, isn't it? Rotterdam criteria is no longer used. Please take your time and read up to date again. You realize that up to date still talks about Rotterdam criteria and even talks about other criteria as well for the management of PCOS. You, in as much as you can look at the clinical features and say that yes, the patient may have PCOS, you still want to use some of the elements of the Rotterdam criteria to help you. Where you're looking for hyperandrogenism, you're looking for polycystic ovaries, on ultrasound. Okay. All right. Now, next question. You have a 15-year-old girl who presents with concerns of severe acne and infrequent menstrual periods. On examination, she has moderate hirsutism. Her BMI is within normal range. Which of the following findings would most strongly support a diagnosis of PCOS? A, acanthosis nigricans, most strongly supports. B, elevated serum testosterone levels. C, decreased TSH. And D, elevated FSH levels. Which of the following most strongly support the diagnosis of PCOS? Looks like a lot of the candidates on Zoom are getting it right. Good. So the answer is B. So Dr. Mulola, and that is why I'm celebrating Collins' discharge as well. Please, that's why I was like, look at it very well. Is it really A? We are looking at what will most strongly support. So elevated testosterone levels is a key biochemical indicator of hyperandrogenism, which is central to the diagnosis of PCOS. The other findings are less specific. Doctors, please. The other findings are less specific. Well, Dr. Mariam, you are saying more specific is dihydroepiandrosterone. Unfortunately, that is not in our answer options, right? So that is another thing we want to pay attention to. So in all these options, the more specific one is elevated serum testosterone levels. So we're not going to leave any stone unturned so far as this particular topic is concerned. All right, sure. Now, which of the following best describes the relationship between insulin resistance and polycystic ovarian syndrome? A, insulin resistance is uncommon in polycystic ovarian syndrome. B, insulin resistance is a cause of polycystic ovarian syndrome in lean individuals only. C, insulin resistance plays a significant role in the pathophysiology of polycystic ovarian syndrome, regardless of BMI. And D, insulin resistance in PCOS is due to hyperthyroidism. What's your answer? Is it A, is it B, is it C, or is it D? What's your answer? The answer is insulin resistance plays a significant role in the pathophysiology of PCOS, regardless of BMI. Now, insulin resistance is a common feature of PCOS. We've learned about that and contributes to its pathophysiology, even in patients who are lean. Okay, so we are looking at PCOS from all its facets, and that will help us to be able to ace the exam.